Welcome. I'm Rebecca Edelmayer, Senior Director of Scientific Engagement with the Alzheimers Association. Today, we'll be talking about a newly approved FDA treatment. Before we begin, we want to share that this webinar is not underwritten by any individual or group of companies. It is organized, arranged, and supported by the Alzheimers Association. Of the association's total contributed revenue in 2020, 0.89% was from the biotechnology, pharmaceutical, diagnostics, and clinical research industries. Given the subject of this webinar, it is important to specifically disclose that 0.15% of total Alzheimer's Association revenue, a total of $525,000, was contributed by Biogen and Eisai in 2020. More details are available publicly at alz.org/transparency. Please take a moment to review the speaker's disclosures. Joining me today are Dr. Alireza Atri and Dr. Eric Tangalos. Dr. Atri is an internationally renowned cognitive neurologist, neuroscientist, clinical researcher, and educator in the fields of Alzheimer's disease and related dementias. He is the director of the Banner Sun Health Research Institute in Sun City, Arizona, and also serves on the faculty at Brigham and Women's Hospital and Harvard Medical School in Boston, Massachusetts. Dr. Eric Tangalos is professor of medicine at the Mayo Clinic in Rochester, Minnesota. He was chair of primary care internal medicine from 1997 to 2006. Dr. Tangalos received his undergraduate training from the University of Michigan, is a graduate of the Loyola University Stritch School of Medicine in Chicago, and was a resident and fellow in internal medicine at Mayo. In today's webinar, we will be discussing aducanumab, or otherwise known as Aduhelm by its trade name, the recommendations to identify appropriate patients, the importance of early detection, and opportunities for collaboration in the patient journey. For those of you attending live, you are welcome to submit questions in the Q&A. We will be reserving time at the end of to do some answers and questions, to answer some of your questions, excuse me. Dr. Atri and Dr. Tangalos, thank you for being here today to discuss this very important topic. As many of you know, on June 7th, the Food and Drug Administration approved aducanumab with the brand name Aduhelm, and using the accelerated approval pathway. Accelerated approval allows for early approval of drugs that treat serious conditions that fill an unmet medical need. And based on the review, the FDA determined that there is substantial evidence that aducanumab reduces amyloid plaques in the brain, and that the reduction in these plaques is reasonably likely to predict important benefits to patients. Accelerated approval also allows the FDA to monitor treatments as they reach the market and collect additional data to verify clinical benefit. The FDA requirement that the company conduct an additional clinical trial is to verify this outcome. It's very important and it's very necessary. The Alzheimer's Association believes this confirmatory trial should begin promptly. I'd now like to begin some of our discussion. Dr. Atri, I'd like to start with you. What does the approval of this drug utilizing the accelerated approval pathway mean for the Alzheimer's and dementia field?
Well, thank you, Rebecca. Thank you for the Alzheimer's Association, and also to Dr. Tangalos for being a partner in this. I appreciate being given this opportunity to talk to you about this. I think it ushers a really exciting new era for us to develop new treatments and to layer them together to attack a really, really complex disease that, is incurable. Alzheimer's disease is an incurable disease, and it's progressive, relentlessly progressive. And, for the first time in 18 years, we have another drug in our armamentarium that works on the biological basis. It's not a cure, far from it. And, but it is an advance. And, what history has shown us from other fields is that, first approvals can really energize the field and allow us to bring, the drugs to patients sooner, to learn from them, to refine them. And, this happened even in Alzheimer's disease. The first generation of drugs that we had in 1993, they were given 4 times. They had some side effects. And actually, we don't use that drug anymore because 4 years later, another drug came along, donepezil, that's generic now. Then after that, there were 3 more drugs, rivastigmine, galantamine, and then memantine, which was another drug. And again, these drugs put together in combination are FDA-approved drugs that work on the symptoms of Alzheimer's disease and to mitigate long-term clinical decline. And the thing that's exciting about this approval, whether there has been a lot of stuff that you probably read in the press regarding the process and what kind of effect it has. It was the drug itself was approved on the basis of lowering and reducing amyloid plaques in the brain, and we know that amyloid protein is one of the major components and one of the defining features of Alzheimer's disease, along with the phosphorylated tau tangles. But that this process of these sticky and toxic proteins like amyloid, they really start 15, 20, 25 years before individuals show symptoms. And so, the idea of being able to give drugs really, really late in the process and having a large effect by itself, we know that's something that we don't have and can't expect. But what we can expect is what happened in other fields, whether it's the cancer field, where it's really highly expected now that individuals come in on standard of care and they get drugs in combination layered on top of each other. If you think back to the HIV, when I was in medical school in San Francisco, all my patients died. And, based on a surrogate endpoint at that point, that, the first drugs for HIV were approved. And this is what basically has happened with this drug, aducanumab. The approval is based on reducing the plaques with a reasonable chance that this will affect to slow down clinical decline. Well, with the first HIV drugs, the surrogate marker was white blood cells. And we know that those first drugs by themselves were not effective as much as we wanted to. But in combination later on, the cocktails have really changed the course of HIV from a death sentence to a disease that, if detected properly and managed properly, can be something that's chronic. And we use this approach in the same way with blood pressure, with cholesterol medications, et cetera. So I guess the bottom line is that, this drug works on one component, the amyloid. It doesn't work on the tangles, the inflammation, the vascular changes, the metabolic changes, and we need to affect those also in combination. But it's, I think, an exciting start. And looking at the bigger picture, when you look at the Alzheimer's disease pipeline now compared to 10 years ago, you see an incredible amount of diversification in the other phases. They're not just all about amyloid drugs. They're about other drugs also that are in the pipeline. And the lessons we're learning from this and bringing into clinical practice in a responsible way, in a very conservative way, is very, very important, to bring it in with guardrails and to learn about it more as the other drugs percolate through research. I think is really important. And to me is an exciting opportunity to actually improve timely detection, appropriate diagnosis and disclosure and care.
Thank you, Dr. Atri. And I think you mentioned in particular that this new drug really is aimed at targeting one of the hallmarks of Alzheimer's disease, those amyloid plaques. But it also is a slightly different approach to treatment in terms of how it's administered compared to previously approved FDA medicines for Alzheimer's. Can you talk a little bit more about how aducanumab works and how it's administered?
Sure. I think especially now with the pandemic and COVID-19, there's been a lot more discussion about monoclonal antibodies. And this is a anti-amyloid monoclonal antibody. And actually, it's interesting because it was developed in a kind of a reverse engineering way where they looked at individuals who were much older and seemed to have very little cognitive decline. And actually, that's how these antibodies were first discovered, and they're antibodies to amyloid. And so what they do is they are targeting, forms of this protein. So you have the amyloid protein is, can be a 40 amino acids or 42. The 42 part is toxic. We either make too much of it in early onset familial types of Alzheimer's disease, but in late onset, the thought is that we're not getting rid of it. And the proteins themselves, these are toxic to synapses, but then they start aggregating and at some point become insoluble and form into plaques. And this aducanumab targets sort of the removal of plaques. And it's different because it's not an oral medication, it's an IV medication. So it requires every 4 weeks to come in and over about 45 to 60 minutes to get a drip, to get up at an IV placed and get a drip, and to have that as a monthly infusion. And so that's different for our field. So in that sense, rheumatologists and oncologists and some other drugs that we've had for MS have been that way in the first generation. So in that sense, it's no different, but it does require titration up. There are risks involved with it, and all these require a serious discussion with patients and families, because it's not a simple yes or no answer. Whether somebody should be on this drug. And the FDA label was very, very broad because, again, it actually stated that this is for the treatment of Alzheimer's disease, for the reduction of plaques. And there was less guidance regarding how to apply it clinically. There were some parameters in the FDA label, but really the studies were done in a very narrow population, which I think is important for us to discuss. And as we're over the next several months, there's some consensus brewing in our field that's going to involve probably who are the right patients for it, how it should be done, how it should be monitored, and that's something that we need to really make sure that we have the guardrails for that. So it's not for everybody who has Alzheimer's disease at every clinical stage.
And that's a good point. I'd like to actually dig a little deeper with you into that particular question in terms of what we learned from the clinical trials. Who were the clinical trial participants, and how is that going to inform, I think, some of those guardrails that you speak of?
Sure. So the clinical trial participants, and let me go back again. This MAB approach is not something that's new. It's been refined over almost the last, I would say, 15, almost 18 years. So I've been involved, with some of these studies. Full disclosure, you'll see from my disclosures, not just with Biogen as a site PI and also as a consultant, but with multiple other companies as a clinical trialist and a clinician. We started this approach years ago, and years ago, we were giving it to individuals in later stages of Alzheimer's disease clinical, so moderate stages, mild to moderate stages, without biomarker confirmation that actually they had amyloid plaques in their brain. And one of the amazing changes in our field is the development of biomarkers, of being able to actually measure while individuals are alive that they have plaques through PET scans or through spinal fluid, and now in research and eventually come to clinic, some blood. So individuals were really those who had biomarker confirmation that they actually had plaques in their brain. And that's really important because an individual that shows up, they may have memory problems, they may have other cognitive issues, they may be in the mild cognitive impairment stages or mild dementia stages. But in those cases, not everybody actually has Alzheimer's disease. We understand that there's other proteins that are very related, and depending on where they aggregate and which systems they affect, they could mimic Alzheimer's disease very much so. And that's what happened in the earlier studies. Without biomarkers, about 18% of individuals were actually who clinically appeared to have Alzheimer's disease actually didn't have enough plaques. So for these studies, they had to actually have a sufficient amount of amyloid plaques in the brain. They had to be in the mild cognitive impairment stage or the mild dementia stages. And of course, that is a in some ways a continuum. So in the mild cognitive impairment stages, there are both subjective symptoms that are also confirmed objectively through testing, but generally individuals are maintaining most of their independence. They may be compensating in other ways. But in the mild dementia stages in that continuum, there has been some changes in independence. So they have to be that stage. So not for individuals who have the biology of Alzheimer's. So there are individuals who have plaques, as I mentioned to you, they form over 10, 15, 20 years before individuals show symptoms. But if they don't have symptoms and they're on the MCI stages, that's not where the population was studied. And also in more advanced stages, so moderate dementia, severe dementia, end-stage dementia, the safety and efficacy was not studied in that population. There were criteria for entry. There were through scales, the Clinical Dementia Rating Scale. They had to have MMSEs. Generally, the MMSE range was about from 20, just to give you an idea, it was between 24 and 30. That by itself doesn't stage somebody, but along with the CDR and some other memory tests, that was a sort of the clinical profile. They had to have amyloid positivity through a PET scan. They also were actually tested in the study for this ApoE genotype. They really could not have had, major strokes. They could not, the individuals with large amount of white matter changes in their brain were excluded. You had to have, you couldn't be on anticoagulants. That's really, really important. And we can talk about that more. Generally, medical conditions had to be well managed and not unstable. So you couldn't have, CHF, you couldn't have, out of control diabetes or high blood pressure or a number of things like that. You could be on concomitant background Alzheimer's medications, so the cholinesterase inhibitors and memantine were okay. And this was another big point. You had to be able to have to get an MRI. And in the MRI, individuals who had more than 4 microhemorrhages, and we can talk about that more, were not allowed. Or if there were any cortical infarctions that were more than a 1.5 centimeter, were not allowed. And of course, during the clinical trials, they had to have a reliable care partner, and there was informed consent. So you notice this is a narrow population. This is not the wide population of everybody we see in clinic. And that's one of the major reasons why many of us in the field, even though we feel this is an incredible advance and it allows us to springboard and learn from it and provide this to our patients who can go through informed consent and would want to have this drug in the appropriate way. It's not for everybody, and there have to be some guardrails.
Mm-hmm. And so I'm definitely hearing from you that the individuals tested in the clinical trial then were individuals with MCI due to Alzheimer's disease or early, or what we would call mild Alzheimer's dementia. They had to have evidence of buildup of amyloid plaque in the brain to even be included in the trial. You can't give an anti-amyloid therapeutic if you don't have amyloid. And that's what we've learned from the studies, is what you sort of described. It won't be efficacious. One other thing,
or potentially safe. I mean, I think one of the major things we always think about, again, I like to always step back to the principles of medical ethics, above prima non nocere, above all do no harm, right? So we want to make sure the safety of this is there, and knowing the profile and how we discuss it with individuals. Is there evidence of some beneficence? And in this case, the approval was based on reduction of plaques with some reasonable thought that it would affect clinical change or slowing it down. And we can discuss that about, what the clinical trials showed in that respect. But the other parts of it are really autonomy and justice. And so it's really, really important to remember that this was not studied in later stages or early stages for safety either.
Mm-hmm. And so maybe can you just elaborate for a minute or so too on some of the data that was speaking to the efficacy of this therapeutic in the trial? What were in terms of the endpoints, primary, secondary endpoints that were there, as well as some of the amyloid in the brain?
Sure. So I'll start with the biological effect. So I'll give you a kind of a overview. So again, not a cure by any means, really the idea is with continued infusions, the probability of reducing plaques was very, very high. And along with that, there was a suggestion in one study, and we'll talk about that, that depending on multiple measures that were used, that we use in clinical trials that are quite validated, that there was somewhere between a 20 to 40% reduction in decline. So this is not a drug that you give one infusion and the expectation is, I'm going to go back to the way I was 2 or 3 years ago. Unfortunately, that's not the case. Really, the expectation would be, at best, this modest but meaningful slowing of decline on cognition, on ability to manage independently, so daily function. There was actually quite a large signal for behavior, which was really, really important, and kind of global decline. And then, of course, with it comes the burdens of getting scans, getting the infusion, and safety. So as far as the biological effect goes, as I mentioned, it's a reasonable assumption that you can take one of the hallmarks of the disease if you do it early enough. And the question is early stage clinical Alzheimer's disease early enough or not to have some effect on other markers and clinical decline. But the answer was very, very clear from both of these. So there were 2 studies that were done. There was the ENGAGE and EMERGE. There were phase 3 studies. We're talking 3,000 patients. And the issue is one of them started earlier and the other one followed, almost 9 months to a year later. Okay, so one starts off, and while that's going on, those are phase 3 trials. There's also an ongoing phase 1b trial that they're still learning about the dosing. So what happened was that, as this is going along, there's an amendment, and they realize that they can actually bring up the dose to the highest dose, which is 10 milligrams per kilogram, partway through these studies. And so an amendment comes in, and they make the change. And so with that, one of the studies that has started earlier, not enough of the patients in that actually got the 10 milligrams per kilogram for enough dosages. Hence, what ended up happening is that you had one study that read out after the fact, and there's a whole bunch of issues regarding. There was a futility analysis. Initially, they thought that when they pooled everything together, it had more of the earlier study population than the second one. They thought maybe there wasn't a reasonable chance that this was going to work. But once they actually looked at the unblinded data, they realized that the one study that had started later, the EMERGE study, was positive, that it had, not only did it clear amyloid from the brain on average, both studies did that, but also had effects on these clinical endpoints. So that was a positive study. The other study was a negative study. And the way I explain this is sort of like, imagine that you're taken off on 2 trains, or you're getting fed, and one goes up on earlier, and you change the menu, and you give more people something to eat, and you're serving from front to back. Well, it turns out that the train that leaves earlier may come into the station and people have not had enough to eat by that time. And that's basically kind of what happened in these 2 trials. But one thing was clear: it does affect reducing amyloid from the brain. So that was number one. From the efficacy standpoint, as I mentioned, EMERGE was a positive study, ENGAGE was a negative study. But what was remarkable about it was that it wasn't just one measure. All the primary and secondary endpoints in EMERGE were positive, were clearly positive. So the consistency of that, goes along and gives us a sort of if you take a broader view, that actually is something that is very positive. And then beyond that, some other folks, the company has done some analyses and presented it, but some other colleagues, like Dr. Suzanne Hendricks, who's well known in the field, she presented some data where when she combined all the studies endpoints together in what we call a global statistical test, and looked at individuals who had got the higher dose for long enough, they were very, very consistent. And then what's the other thing that's remarkably consistent is that, aducanumab is not the only mAb in town. There are other mAbs, donanemab, lecanemab, gantenerumab, and even solanezumab that have been studied, and some are continuing to be studied. And you've probably heard, in the news that some of those recently have shown very similar trends, which is about a 30% slowing of cognitive decline. So that's the good news. What's the downside is the safety part, is ARIA. And what's ARIA? So ARIA is these amyloid-related imaging abnormalities. They were first seen in bapineuzumab, we're talking 15 years ago or more. And they involve, basically, if you take MRIs, you can see small areas of effusion, so a little tiny swelling. It could be millimeters, or it could be as much as 1 to 2 inches, or in some cases much more, or a little bit of leaking of blood through blood vessels. Why is that? The blood-brain barrier in Alzheimer's patients is leaky to begin with, and these drugs, the mechanisms actually moving, the amyloid out of the brain through antibodies. And so the hypothesis is as you're moving these along, you could have more leakiness. Now, it's important to realize that even on a background, so without giving any MABs, if you were to do repeated MRIs on individuals, right, to begin with, 15 to 20% actually have microhemorrhages. So the blood may be gone, but you can see evidence around the small blood vessels, a little bit of hemosiderin sitting around. But if you follow individuals in the placebo group, about 10% on average have these leaks anyhow, right? The issue is that when you give aducanumab, and particularly at the higher dosage, that number gets not from 10%, it gets to be more like 40, 41%, okay? And of which case, about 75% of them have no symptoms. So individuals can have these, we just pick them up on MRI scans. But about 25% have symptoms, and they could relate to any kind of symptom to the brain. So they could have headaches, they could have momentary confusions, they can have numbness, tingling, nausea, imbalance, and about 6% of the individuals had to actually stop because of this, or did stop, and about 1 out of 200 to 300, so the report that was rated, the rate was about 0.3%, actually had a serious effect and may have to be hospitalized because of those symptoms. So that's really the safety part of it. So I'll stop there because there's a lot more to discuss about biomarkers and what we saw in the studies.
No, but I think those are some excellent points, Dr. Atri, because I think what it is telling us, though, is based on the clinical trial data, even in the presence of these potential side effects, there is guidance around ARIA management, but it will require some additional clinical vigilance, and this is why MRIs are necessary. And it speaks a bit to also the approaches that will need to be taken in the future in terms of clinical care, as if someone is put on this treatment moving in the future. I know that the Alzheimer's Association is actually is developing an upcoming CME around ARIA and its management, and that will be available soon, and we'll be able to make sure to send information about that program to all our listeners today when it becomes available. But thank you, Dr. Atri. I think you've provided a wealth of information for us. I do want to transition to Dr. Tangalos. Dr. Tangalos, in your practice, you are familiar with drugs that have been previously approved and prescribed to treat symptoms of Alzheimer's. Can you speak a little bit about how this might change your practice and how this new drug differs from those?
This is a big opportunity because we haven't had a new drug since 2003. And so this one works completely different. It goes after the underlying biology of Alzheimer's disease. And as we go through with the earliest patients that get put on it now for clinical care, it may mean that there's more time for individuals to participate in daily activities of living so they can stay more independent. I mean, that's what we want right now, is to hold on to memories, to not transition. And again, because the patients that were used in the clinical trials are really the patients we should be thinking about to start with this therapy, they should be early in the course of their disease, which gives us more opportunity to keep them as independent as possible for a longer period of time. Now, let's remember that it was approved for patients with Alzheimer's disease and the MCI due to Alzheimer's disease. Now, there's a bunch of different types of MCI, but the bulk of them now have what we call MCI due to Alzheimer's disease. So the targeted pathology is, as Dr. Atri pointed out, the amyloid plaque, and there's opportunities now with this therapy to remove amyloid from the brain. It's not been tested on people with more advanced cases of Alzheimer's disease or dementia, and the treatment's not a cure. As we've said before, it's pivotal. It's a new opportunity, and the FDA says that this stuff does its best job on the elimination of amyloid. The clinical determinants are still ongoing. We want to encourage those patients and those clinicians that get involved with this therapy to give us more data on the clinical responsiveness that patients may or may not have.
That's an important point, and I think a lot of that data will be coming from many of your offices as you continue to start or really even start treating individuals with these therapeutics. Dr. Tangalos, I can imagine that you're already dealing with a lot of questions, a lot of patients coming to your office asking questions, wondering if they can receive the drug, family members who may be asking you as well. And even probably providers are going to want to ensure that, you know, they're continuing to provide impactful and quality care to your patients. So can you talk to us a little bit about what conversations may look like for you in the care setting today? What kinds of questions are you having to answer?
First of all, we have to understand that at each location where the therapy is going to be offered, because the FDA guidance is actually quite broad, it's going to be received and handled in a very different fashion. So I think the first advice to give is that there's not going to be one straight, legitimate, universal approach, and that physicians, primary care included, need to understand what the resources are going to be available within their community. They are going to have to help the patients that have the best profile to receive this kind of therapy so that the outcomes can be the best. And I think those are the overriding discussions that we have to have. And we don't want clinicians to get caught flat-footed without an understanding of this treatment. It is a biomarker-based treatment. It is incredibly effective at removing amyloid from the brain, and yet the clinical determinants have to be decided as we go forward. So again, if I'm repetitious, we want patients and their providers to be as successful as possible. We want the drug actually to be as successful as possible as well. So it's the selection process that's important. And it is going to be important because the target is amyloid, for clinicians to understand biomarkers, and for clinicians, whether it's the primary care doc, which is unlikely, or the neurologist or the referral center, to be able to get the appropriate scans and biomarkers to prove that amyloid is there as the target that needs to be treated. So it's first generation, first in its class, an honest discussion. The risks and side effects, because it is so targeted to amyloid, there's not a lot of other side effects outside of the brain. They all are related to the ARIA phenomenon, more or less. And so these are relatively clean drugs because of their because of how they work as immune therapies, and they work very well in that way.
And so,
one more thing, each person is going to be different, and unfortunately, each provider and patient is going to be an N of one. So as the FDA looks at these things, and as we look at clinical trials, you have to aggregate, and that's where these 3,000 patients came up, and that's why you have to look at the aggregate data. So any individual is going to respond in a very unique way.
Yeah. And as I expect to many therapeutics that are out there, very similarly, as a clinician, I'm sure you're watching them all very carefully to see about the actual response. And maybe I want to switch a little bit with you, Dr. Tangalos, and talk about the importance of early detection. We know that there's been hesitancy among clinicians and even patients to talk to each other about Alzheimer's or any cognitive concerns or changes that they may be seeing. How is this new treatment going to impact the need for that initial conversation?
Well, first of all, this puts another arrow in the quiver for the clinician to approach the disease. And we have been talking about running toward the diagnosis of Alzheimer's disease instead of away from it for a long, long time. Now that we have MCI defined as the MCI due to Alzheimer's disease, it's all the more reason to run forward and make the diagnosis rather than avoid the diagnosis. We think that there'll be a whole new group of patients and families tuned in to the possibilities of this treatment option. And the earlier we make a diagnosis, a legitimate, appropriate diagnosis, and not dismiss the patient's symptomatology, the better off we are at getting the right patient in for therapy. Because even with the cholinesterase inhibitors, the earlier you address their cognitive problems, the more likely you were to have a positive outcome. So the same thing applies here. The sooner you make a diagnosis, a legitimate diagnosis, the better you can decide what patients should be referred for earliest therapy. And again, we want the drug and the patients and their families to be successful. So it is concomitant upon primary care providers to look at the disease state and determine where this patient may fit. I think we're making a mistake by taking someone with advanced disease and carrying on a lengthy discussion. I think we're more appropriate taking that earliest case and saying, you know what, if you're interested, or I have a particular interest in this, I know where we can go to get the next level of discussion so that you may or may not be approved for this treatment.
Now, and I think you definitely brought up a critical point here that we wanted to make sure to get across during this session today is that coordination and collaboration that needs to happen between the primary care physician or the generalist, as well as the specialist, that might really make sure that the patient is getting the best quality and comprehensive care possible as part of that patient journey and part of that process. I would actually like to transition to both of you, maybe ask you this question here. Could you both talk a little bit about conversations that you're having in your practices and what that type of collaboration could look like throughout the patient journey?
Well, let me finish with the piece about the amyloid. In my practices, even as an Alzheimer's researcher and someone that specializes in this kind of thing, I've never been able to get an amyloid scan approved. It's a hallmark right now of how these patients were studied. And I couldn't do this without the assistance of a neurologist and essentially a clinical approach to the care that required this.
It does speak to be able to coordinate some of the diagnostics that are absolutely going to be necessary too, to make sure that people get on the right care path.
Yeah,
Dr. Go ahead.
Go ahead. Yeah.
Go ahead, Dr.
I
Atri.
agree. I agree with Dr. Tangalos. I think this is a really exciting opportunity for us to finally develop, this network, this hub and spoke model that oncology and some other conditions have been able to develop over years, where there's very, very close collaborations between primary care, specialty, and subspecialty care. And it's doable, and it's going to take time. It's going to take effort and relationship building, but there are not enough subspecialists to detect everybody and sort of do the early part of this work, which involves identifying individuals in early clinical stage of AD, ensuring that, they're roughly in the right stages. A close collaboration with radiology and nuclear medicine specialists, because they have to be able to, read the scans, both from the MRI standpoint to ensure that there are not too many microhemorrhages or strokes, et cetera. If we're going to stick to a close resemblance of patients in clinical trials, with nuclear medicine specialists to make sure that they have enough, amyloid. In some cases, maybe spinal fluid may be a viable alternative. It's actually done in Europe quite a bit, and we get information out of that. Of course, the coverage issues have to be dealt with by insurers, so that's going to be really, really important. I mean, this is by definition for treatment of Alzheimer's disease, so the biological piece is important. So at this point, how that's going to be covered is unknown, but that's going to be an important piece. Otherwise, I think that'll be a major issue. And then, so let's say, individuals are identified, they have, let's say, MMSEs in the 20s, or MoCAs, for example. MoCAs tend to be about in that range, about 4 points less. So maybe, MoCAs somewhere between, 17 to 30. They have the right biology. And then you'd want to have a team, right? A hub and spoke model of specialists who can say, yes, well, there's, the inclusion criteria fits. And then you're going to have infusions, right, that are titrated. So you don't get the maximum dose right off the bat. So you have to get that infused. I have titrations that come up. Right now, the FDA label suggests that there has to be an MRI done within a year of starting therapy, and then before the 7th dose and the 12th dose. So you start at 1 milligrams per kilogram, you do that for a couple, then you go to 3 milligrams per kilogram, a few doses, then 6, and ultimately 10. There may be appropriate use criteria that suggest that there may be more monitoring than that. And then if ARIA develops, what do you do with that? And as you mentioned, the association is going to help with educating our clinicians to monitor and deal with that. But I think, the other part requires a really important kind of honest, thorough, and comprehensive patient-centered discussion, one that's optimistic but realistic regarding, the benefits, clinically, biomarker, modest benefits that, are expected to be lessening decline, right? And how do you, so that's going to be an ongoing discussion, because are the risk and burdens worth it? So that requires knowledge and appreciation of facts. So that requires, again, somebody who's knowledgeable, talking about probabilities and uncertainties regarding, side effects, benefit, risk, and making sure that patients and families can prioritize regarding what they're willing to, what is their risk reward tolerance. So this is not a drug for everybody. I think it requires this comprehensive team. It's totally doable. Like I said, we've done it for MS and oncology and stroke care, et cetera. But it's just a new opportunity for us to develop those networks and those connections.
Yeah, and I expect this new therapy will elevate everybody's game, so that the primary care doc is going to have to know more about this. They're going to have to work more closely with patients and families and the specialists all around them. And they're going to need to do as good a job, if not a better job, optimizing the medical care that may be concomitant to their Alzheimer's disease. Again, looking for the best outcomes in these earliest patients that are going to get treated.
And I think that those are all incredibly important points, and it really speaks to the coordination that's going to be necessary. I do want to take a question that has come in at this moment before we kind of continue, because I want to make sure that it's clear. The question was, what biomarkers would we need to check? Is that a blood test or a lumbar puncture? But I maybe both of you could elaborate on that, because I thought it was clear, but maybe we're not being clear about what was used in the trial and what we anticipate seeing moving forward in clinical care.
So I would say that absolutely necessary. It says on the FDA label that an MRI needs to be done. So that's a biomarker in itself. And I would say there's clinical biomarkers. So whether, what stage are they in? So they're MMSE or MoCA, or making sure they actually fit the right clinical profile. So there's that. There's the MRI, which is going to be important. Again, the question becomes, how many microhemorrhages, things like that. And then there's going to be something to ensure that they have amyloid in their brain. So that could be a PET scan, an amyloid PET scan, or it could be an LP from a spinal fluid. And both of those have appropriate use criteria for them already. The blood biomarkers are evolving, but they have not been validated clinically, even though there's some actually now available. They really have not been validated clinically yet. Eventually they will be, I think, but they're not yet, and there's no appropriate use criteria for them. So those are for inclusion. Now, what do you do after that? The biomarker really is for safety, is the MRI, and there'll be a number of MRIs. And then how do you monitor changes down the line? That hasn't been determined either, as far as whether there's going to be another PET scan done eventually, or could there be a blood biomarker that is linked to the PET scan or the spinal fluid. Those have to be determined yet. So I think hopefully that answered the question.
I think it does. It was important, I think, that we stress that sort of process that would be needed even before initiating treatment, and also what may need to happen after. Dr. Atri and Dr. Tangalos, this has really been an excellent conversation. I think just to add a few points here, from the Alzheimer's Association's perspective, we are the largest nonprofit funder of Alzheimer's and dementia research in the world. We understand the enormous significance of this approval, but also really the need to continue to advance potential treatment avenues for diverse populations living in all stages of Alzheimer and other dementia. As you've mentioned today, we know this drug will be of great interest to many of your patients, but it is not the only important element of Alzheimer's treatment and care. The Alzheimer's Association has really made it a priority to partner with healthcare systems, physicians, and the Centers for Medicare and Medicaid to ensure early and accurate diagnosis and access to appropriate treatment, care management, and care planning. And this will include a number of things: education of healthcare systems and physicians to ensure proper diagnosis, treatment, and care management. Even with the availability of this drug, we must really ensure proper care in the present and in the future, such as helping manage multiple doctors and finding and using community support services. Even with the availability of this drug, we must ensure that there's proper care. And we need to ensure that there's access. We are calling on the Centers for Medicare and Medicaid to expand the availability of dementia care services under Medicare. And at this time, we do not know what insurance coverage will be for aducanumab. We know that there's many discussions that are currently underway. Infusion therapies have been made available. I think Dr. Atri mentioned this, under Medicare and private insurance for conditions like cancer and multiple sclerosis. So we know it's reasonable to expect this for aducanumab. However, we know it's really important that we continue to eliminate barriers to access, and this is our highest priority. And the Alzheimer's Association will continue to do everything in our power to ensure access to the drug, any tests that are going to be needed during the treatment process, or other associated costs for all those who will benefit. I want to transition now with the last 10 minutes that we have to some questions that we've been receiving. I think you spoke, just again to confirm with both of you as physicians, you spoke about who was included in the clinical trial population and why they were included. And I expect that you'll be having to have some difficult conversations with your patients. What will you tell your patients if they are in a more advanced stage of dementia? How will you talk to them about this?
Well, I want them, I want the therapy to be as successful as possible. I want the patient to be as safe and successful as possible. And this is not a treatment for patients with moderate to advanced disease, at least not at the beginning. Again, it was approved because it removes plaque, it removes amyloid plaque. And so you have to understand to the patient and family that the drug and the benefits of the therapy, you need to find the patient that is going to be most successful all the way through the treatment program.
Yeah, I agree with you, Dr. Tangalos. I think, those really honest and critical conversations are important from the beginning. I look people in the eyes and I said, look, I'll be your honest advisor. I'll tell you the truth as I know it. And in this case, the efficacy and safety has not been looked at. And I've already had a conversation like this with a family member with early onset Alzheimer's. It's difficult. And, some of you may know, I took care of my dad for 10 years. And before that, it was my aunt. And I take care of individuals with early onset, young onset Alzheimer's. Very, very tough. But this is one component and one advance. And guess what? We have other clinical trials. We have other studies. And I think that may be even more suited for individuals who are in the moderate stages. And that's one of the parts I think we shouldn't forget about those individuals. We need experimental trials and therapeutics interventions for them also. And this is only one component. And so I'll have a very honest conversation that this is not the right approach for them. And if they want to be involved in a trial or a study, there may be others that are more suited for them. And that we'll continue to manage and give them multifactorial care with the medicines that we have, with the interventions that we have. And pharmacology is only one part of this.
If our primary care provider is already tuned in and understands diagnostic disclosure, already carries on that discussion sooner rather than later, then the discussion regarding the new therapies is a heck of a lot easier. So again, making that diagnosis early, disclosing the information regarding the diagnosis to set the platform makes it all a lot easier.
I think that's an excellent point. And I think it kind of pivots to another question that has come in terms of clinical trial participation. Dr. Atri, you sort of referred to this. We know it's critical for the development of new treatments, and it has to continue. And aducanumab is just one example of how clinical trial participation has provided so much value, not only potentially to the individuals involved in the trial, but also to the field as a whole and clinical practice as a whole. We know that we must continue to do this research to really discover effective treatments for all individuals living with Alzheimer's and other dementia. So that's probably another question you might be getting in your clinic right now is how do you address questions from patients on whether they should participate in a clinical trial or continue, maybe they're already in a trial, or try this new therapy or other available treatment that might be out there.
I'm happy to take that, Eric, whichever.
Go ahead.
Okay. Yeah. So I always, again, where I am at Banner Sun Health Research Institute, we have, 30-something studies and trials. So we have a menu, for example. And for other folks who are interested in trials, Trial Match, clinicaltrials.gov. But part of it is actually sitting down and understanding. So you may have the same individual let's say you have twins, biologically identical. Let's say they're exactly the same stage of Alzheimer's, early stage, same scores, everything the same. When you have that patient-centered discussion that's honest and looks at their priorities, their risk-reward calculus, one may opt to do one thing and the other one may opt to do something else. And that's part of that ongoing discussion. As far as, stopping other treatments, I think it's important to explain what the uncertainties are and what the likelihoods are, and then allowing the patients to have that the autonomy to make that informed decision. And then the other part of it is really important, the justice part of it you mentioned, right? And I think that's really, really important to make sure that all individuals have access to early detection. Because what we're finding, as you mentioned, is right now we just get the tip of the iceberg. Everything else, the bigger part is sitting below. And this is an opportunity for earlier detection and more accurate diagnosis. And the things we learn with biomarkers and the approaches to this drug are going to apply to other conditions, to Lewy body disease and other FTLDs, and we understanding other proteinopathies, TDP-43. So Individuals who are in their 70s and 80s tend to have at least 3 different things. And here we are with one drug hitting one component. Explaining all that and then allowing individuals to make their decisions.
And I think you alluded to this, Dr. Atri, in some of your comments, but another question around the fact that some individuals that were in the aducanumab trials were on concomitant therapy of other approved Alzheimer's treatments. So I anticipate that you will be treating some of your patients potentially with other FDA-approved treatments for some of the symptomatic treatments, I suppose. But then
absolutely,
also
yeah. About 2/3 of individuals were already, in these studies were on, depending also on the stage, were on background medications, oftentimes a cholinesterase inhibitor. Remember, those drugs are generic, pennies on the dollar, with profiles that we understand. And so absolutely, the idea is to layer these on top of each other. The other thing is some of the studies that are underway as aducanumab and drugs like it, may become standard of care, they become just like oncology. They become layered on top. So there are clinical trials that are starting or have started that have said, gosh, you may be on a drug like aducanumab, that's standard of care for you. You can still come into our study as long as you've, maybe gone through 12 months of this, things are stable, you've been monitored, etc. So this is, again, an incredible opportunity for our field to look at layering drugs on top of each other. That's what we need to do. There's not going to be a magic bullet. This is definitely not it. But it is an exciting opportunity for our field to do that.
So, but we're running out of time here, but before we wrap up, Dr. Atri and Dr. Tangalos, I do want to take some time to first thank you, but I would like to ask you both maybe to provide some brief final thoughts before we end the session today. Anything that maybe we haven't touched upon that you would like to say? Maybe Dr. Tangalos, could we start with you?
Sure. This is actually more a personal thought. Probably 20 years ago, I was on the national board of the Alzheimer's Association, and I had a chance to meet with and talk with Paul Harvey. And I told him at the time, in my lifetime, there would probably be a cure for Alzheimer's disease. Now, the clock is still ticking on me, but at least the field has advanced with this new introduced therapy. And I'm really delighted that we're moving the dial.
Thank you very much. Dr. Atri?
Yeah, I agree with you, Dr. Tangalos. This is not about proteins, that go awry. It's not about PET scans or p-values in clinical trials or power, et cetera. It's really about people. It's about people, persons with Alzheimer's disease and related dementias, their partners, their families, their loved ones who are impacted by this disease. And, we need to always think about doing right for them. And I think this is an exciting and important step forward for hope and care in our field. And we owe it to each other to think of this as, just us and we. And together, rising to the occasion as a community to maximize this opportunity to advance knowledge and therapies and improve diagnosis and care. And I think we can. I think we need to, for this particular drug, moderating expectations, knowing that aducanumab is not a cure, but it is a rational basis for hope, and tempered by cautions and complexity, but it's doable. And I think as we're reaching consensus within our community and building these networks, I think that this will end up being in our practices and your practices something meaningful, one way or another, as a component that's going to help drive earlier detection, accurate diagnosis, and a multifactorial care for patients and families. So I'm hopeful, and I thank you for being involved and being part of this fight to help patients and families, because them is us.
Thank you so much for being here, and thank you for those words. I think both of our experts today have said it all. We hope that you found this webinar informative. For all of those that are viewing today, the Alzheimer's Association has additional resources available for your practice at alz.org/clinical care. keep checking back as we continue to update it with new information as it becomes available. There's still much to learn, but we'll do it together. And so I want to thank you all for attending and enjoy the rest of your day.
Be well, everyone. Thanks.
Bye-bye.